diverse group of people we've worked with. We have doctors, of course, and PAs and nurse practitioners. And, so we have a pretty good crew. POs, MDs, everybody. So we work pretty much at all of our little places. It's a good little group. So we're going to start. We got 4 lectures. So, and we're going to go through each one of them. Hopefully take a little break. Hopefully my voice will hold up, and we'll get this done. Okay. So, any questions before we get started? No? Okay. So don't forget to vote today. So I'm going to keep you here for 4 hours. So you can vote. So emergency medicine, so a little bit different thinking sometimes than your clinic setting. You know, it can be a little bit, you know, is this person sick or not sick? You know, kind of a mentality. It may not be actually getting to the heart of the issues of, you know, the background things. So sometimes that's frustrating for people. I see you guys come in for your rotations, and some of that seems to be the first thing that kind of struggle with a little bit. You know, actually, what kind of tests you want to order, and you're ordering kind of rheumatological, you know, things for people's joint pain or something. You know, there's a little bit of a shift in the types of things that we'll do and won't do. So, anyway, let's get started with everybody's favorite subject. Psych seems to freak people out. I don't know why. But we see a very large mental health population in our area. Part of that is due to where we are located, you know, kind of in the heart of downtown, midtown area, which even though it's gentrifying and changing, and you know, there's little people with scooters rolling around everywhere. We have a scooter count, by the way. We have, when I was last there, we had, I think, 20 injuries from scooters. So, mainly wrist fractures, a subdural hematoma. Don't let your grandma ride one, especially if she's on Eliquis, okay? A lady with bilateral tibia fractures. So, yeah. Be careful if you're riding one of these things, okay? Or just don't ride with it. That's probably even best. Anyway, so our area, you know, because of, you know, 10 years ago, the area that where St. Anthony's was not good. It was pretty run down, large homeless population. There was a bus station not too far away from us. There, you know, still is the City Rescue Mission and Salvation Army and all these different places. So there's lots of halfway houses in the area. So population has a large contingency of people that have mental health problems. And so, plus the other part of that is that we kind of get the curse of the competent too. So, you know, had this probably happen to you before, where you do something well and people come to you over and over again because you do it well. And so we kind of do it pretty well. We get people from all over. You're like, why did you come from Guthrie? Ask 6 hospitals to come to us. You know, the patient's never been to us before. We don't have any relationship with this patient. Well, we heard you're the psych hospital. Well, that's not really true. You know, we're doing the same thing that any emergency room can do. We're medically clearing a patient and trying to find a placement, those kind of things. So we'll kind of go through what we do in the emergency room here. All right. So these are just a little enumeration of some things that have been written in notes, which you can kind of look at to kind of see what kind of patients we're dealing with, funny stories. You know, I mean, so probably a homeless person, right? You know, and I don't know if we have sewer rats here, but you know, that was their impression of it. So very interesting history there. I like the allergy to chocolate too. So this is probably my favorite chief complaint ever. So what I even love most about it is the triage nurse put in that it's an animal bite or scratch. Like an Ewok is an actual animal. That's really funny. And then you can put the HPI comment so you see, the patient appears intoxicated. We need to finish that word there. So, okay. And this one's just kind of sad because it's a kid. Kids in their feces, when they have mental health things, it seems to be a go-to. Eating it, smearing it. Fun things there. Alright, so this is what we're going to talk about. We're going to talk about the acutely psychotic patient, okay, suicidal ideation, attempt. We're going to go through some manic people, anxiety and panic attack, drug abuse, substance dependence, and a little bit of child psych. Okay, so the approach to the psychiatric patient. Okay, obviously in the ER we're not going to cure their mental illness, right? So what are we looking to do? We're looking to get them to a place that can help. Okay, sometimes that's an inpatient facility. Sometimes that's a outpatient resources. Okay. And sometimes people aren't happy with what we decide for them. So, but we need to make sure that whatever they are there for, that they do not have a medical reason why they could be having their psychosis or whatever they're going on. Okay, so this is kind of like a classic example, and this almost seems like kind of cliche, like it's a test question and something like that. But we see this all the time. Okay. So, a 73-year-old female from a nursing home, it's always from a nursing home, with complaints from staff. She's speaking to people who aren't there, she's combative, she bit somebody, you know, she has no prior history of mental illness. This is the weird person, right? And, you know, she's got some medical problems, she had a recent fracture, so she's not moving around a whole lot, okay? What could be going on with this patient?
Infection.
Infection? Okay, all right. What would your first thought to look for? Where would you look for infections first?
UTI.
Somebody said UTI, so yes. Okay, all right. Perfect, perfect. All right. So yeah, this happens all the time. You know, it's probably lack of training or lack of understanding, you know, at the nursing home, but ship them down there and when we get them cleared, we get them admitted to the hospital for a medical reason, or you know, we treat them. Sometimes we can get them turned around with fluids and, you know, dose of Rocephin, and they're no longer combative. They're calm. They're, you know, cured them basically, and we can send them back. And the nursing homes are like, but they were psychotic, but they weren't. So, all right. So here's kind of your workup for a psych patient, and so. This is just kind of the basics. You can order other stuff as well. But, so you know, you get a CBC. So what am I going to get with that? You guys be loud. Right?
See what I'm infection with the
White blood cell count. Okay. Anything else? What could cause some depression?
anemia.
Anemia, right? Okay. All right. CMP. What am I going to get with that? Electrolytes. Okay. Okay. Liver function. So we say kidney function. That's really important too. Okay. All right. Good, good, good. And urine drug screen, I think was pretty obvious, right? So, can be a little bit misleading sometimes, depending on what your screens test for. Ours tests for amphetamines, cocaine, barbiturates, PCP, marijuana, opioids, and benzos. And so, you know, if you get somebody that's not like Vyvanse or something like that, they're going to pop positive for amphetamines. So it's kind of hard to tell if they're actually doing anything else. So if they're on chronic pain medicine, you know, are they also doing heroin? You know, can't really tell. It's not very specific like that. So some drug tests will break it down between methamphetamines and actual amphetamines. So that's kind of handy. All right. It's hard to get the full score, so we have some people that come in with like 5 of the 6, you know, on board. Barbiturates is really hard to get, so you have to get some Fioricet rotated through the community before you get that one. So, All right, so UA, we talked about that a little bit. Urine tricyclics, okay? The psychiatric facilities love this one. They want to have this one on the chart for some reason. You know, there's just not a whole lot of, Elavil out there, a whole lot anymore, those kinds of things. There's a ton of false positives. So, Flexeril, Atarax, Benadryl, can cause a false positive on that. So it's not really a great test, but we get it anyways, because to make the psychiatric facilities happy. So, alcohol level, that seems pretty self-evident. So sometimes we get into problems because we have patients that will come in with their alcohol level being like 400 and greater. And so most psychiatric facilities won't allow the patient to come to them until their alcohol level is below 150. So your alcohol level goes down about 20 to 25 an hour. So it takes a long time. If you're at 450, you're down to 150. So they're camping out for quite a while. And you can't give them coffee and make it better, or fluids. There's just time. Time in your liver is all you get. So acetaminophen level, we're always concerned about, especially if they're doing a bunch of drugs, pills, that kind of stuff. There's lots of Tylenol in these medicines. Make sure they haven't overdosed on something. Cold medicines have Tylenol in them, so if they're overdosed on those, those are important. Salicylate level, again, overdose stuff. And other medication levels, so if they're on medicine that we can get a level on, Depakote, any of these, a lot of seizure medicines have levels that we can get. Are they on warfarin or something like that? Might want to get an INR. Make sure they haven't overdosed on that. Those are all things that we might have to consider. EKG, a lot of patients get EKGs. I think our techs think that we just order them to make them have to run around the ER with a little machine and do them, but they are actually quite important. One, we want to make sure that, a lot of these people come in tachycardic. We want to make sure that their tachycardia is not some kind of heart thing, okay? We want to make sure that it's just, because they're on cocaine or like that. So we, sounds good, bad. I'm wanting it to just be on cocaine, right? But so if they test positive for any of these things, definitely get those. Over 60, they come in tachycardic. If you suspect any type of real overdose or unsure about which kind of overdose it could have been, you're getting an EKG. And we'll talk a little more about this when we talk about the medicines we're going to use, because some of those things can be affected. Chest X-ray, sometimes you get it, sometimes you don't. Not too worried with that. A CK, a lot of our patients on meth and those kinds of things are very, very dry. For some reason, when you're high on meth, you don't want to stop and drink Gatorade. You tend to just run around and not take care of your daily functions. So they're spending lots of energy. They're sweating. They've probably had some kind of run-in with the police. So they run around the place, fight with the police. So we need to make sure that they're not wrapped up. So the first clue is obviously the urine. I would like to take a look, see what their little urinal looks like. If it looks like a nice dark tea, then I'm definitely ordering a CK. All right. So how did you get here? So I think a lot of people, hopefully you guys are past this, but think that everybody comes into the ER by ambulance, and it's like Grey's Anatomy, and the doctors run out there and they're counted up and they go save the day, right? Well, unfortunately, it's not really how it happens. Most of our psychiatric people come in by police. EMS, right about a little bit less, and then family, or they would just walk in by themselves. So, important thing, so when you got somebody coming into the ER and they have somebody with them, a police officer, EMS person, you want to try and get the story. Because it's maybe hard to believe, but a psychiatric patient is not the most reliable historian. Okay, so we want to make sure that somebody who might have seen something, saw something, heard something, might want to write this down. So that's when we use our third-party statements, our peace officer statements for the the police officers. The police have this kind of notion that they are the ones EODing somebody, okay? That emergency order of detention, what that stands for. And so, I EOD'd them. Yeah, don't worry, they're PA, I EOD'd them. No, you did a third police officer statement, or a third party statement. We'll do all the EOD, okay? That's our deal to do. It's got to be done by a licensed mental health provider, which is doctors, certain nurses, PAs, nurse practitioners, okay? And some therapists. So, what we want to do is get the story. So, if there's, basically, they can come in by EMS and say, well, somebody said they're suicidal at home. Okay, great. Who said that? There's patients saying, I'm not suicidal, I would never do anything to harm myself. They're future-oriented, they're wanting to, they're looking forward to a job coming up or something like that. Well, I'm really trying to struggle with this because I want to keep this person safe, but I also, am I willing to take this person's rights away? Because that's what we're talking about. We're taking somebody, an American citizen usually, and saying, we're going to take your rights away and hold you against your will. And so it's kind of a big deal. So, but on the other hand, you don't want somebody leaving your hospital with your wristband on and then jumping out in front of a car and dying. That looks bad on you and your hospital. And then you're on Channel 4 and everybody's freaked out, protesting in front of your hospital and stuff. So we've got to be really careful about that. So it's kind of a very fine line. I like to probably err on the side of caution and probably take more people's rights away than I probably should at some point. But that's why I'm trying to find out who said this. Sometimes the counselor, I don't see any reason why we should keep this person. Well, let's give mom a call and see what was actually going on. Just because the EMS or whoever didn't have anybody to write a third-party statement, the family doesn't know they have to write something. They're expecting that they told somebody this person's suicidal, and then we'll take care of it. So, trying to get them on the phone, find out what was happening, just do a little more investigating. Play Sherlock a little more. So, the EOD, you can get rid of somebody for 72 hours. So if you don't like your roommate, come up with a third-party statement about how they were saying they were going to be suicidal. And, you want to include a plan, okay? Very important that they have a plan. You can be suicidal, but if you're still kind of, especially that, people that are chronically kind of suicidal, I have thoughts all the time, like, I should just die. But, if it's kind of thoughts and they're just kind of depressed and they're getting treatment, and they're interested in getting treatment at least, and that's not really something we need to EOD them for. But if they're talking about, I just want to die, and if you let me out of here, I'm going to grab a knife and I'm going to cut my wrist. I'm going to find a way up to the top of the Devon Tower. I'm going to jump off. These are very specific things, right? We want to make sure that those people are definitely kept. And 72 hours, not including weekends and holidays. So if you really want to get rid of your roommate, do it on a Friday. So that's the longest yet to be kept. So it's not exactly, not always that long. So, but after 72 hours, if the psychiatric facility wants to keep them, they have to go through a judge, unless the patient is willing to stay for treatment. So, the acutely psychotic patient, my favorite. I kind of like seeing how they act and trying to calm them down is always a little bit fun. So they're having auditory and visual hallucinations, maybe seeing things that aren't there, hearing things that aren't there. Those voices might be telling them to do things. They might be telling them that not to trust the people that are in front of you. So you're kind of battling whatever is going on in the head there a little bit. They're delusional. They think something is they hear somebody laughing out in the hallway, and they think they're laughing about them. They're paranoid about things. They have these delusions about, the government has put chips in their brain, and these are very common delusions, by the way. And the other just kind of bizarre behavior, like the nurses kind of say, well, kind of determine how crazy, how psychotic somebody is by their eyes. This one's got the eyes. And it's kind of true, because they kind of have these kind of wide, kind of open eyes, and they kind of stare around, darting around a little bit. It's pretty good, pretty good indicator a little bit. So now I have to be careful, because sometimes it's because of this infection, like we were talking about, this old lady that came from the nursing home. Sometimes it's also withdrawal. So anybody think of a withdrawal that might have some kind of psychoses with it? Alcohol, yeah. So get some delirium tremens, and it's right in the name, right? Delirium. So we can, we want to watch out for that, but that's not what's going on. So management of this is kind of like a subset of my lecture. So kind of this part is actually a lecture I give to actual PAs and NPs and stuff. And so this is how we kind of approach your acutely psychotic or agitated patient. So it's a very, ER can be a very dangerous place, just because of the nature. We're really, really busy. And, my last shift, we had a nurse get punched in the head 3 times. Luckily, one of our other male nurses made an outstanding tackle on the individual, and they went to jail. So, but those kinds of things can happen. So there's a lot of underlying mental health illness in the ER community. So they may be there for knee pain or not feeling well, but they have an underlying psychiatric issue, so we have to be careful with that. So everybody that comes in gets a little bit of a screening. So first off, they have a page that they fill out, and so there's 3 questions on there. Are you suicidal? Are you homicidal? Are you hearing things, seeing things, or are you psychotic? And so there's that, and then the triage nurse asks those questions as well. They do the Columbia screening on all of our patients. And so that'll trigger if there may be some issues that we need to be addressing while we're in the emergency room, or at least take some of the precautions. So that's part of identifying. So this is where we're going to identify, describe the safe way to do things, how to de-escalate, how to use some physical restraints, and we'll talk about some chemical restraints. So to reduce, the whole point is to reduce the risk for the patient and for our staff. We want everything to be kind of, as calm as possible. And so what I call my tactical approach to viewing the patient. So you want to have rooms that are kind of designated for this. Like JCO and some of that says we can't have designated rooms, we do. So you want to have rooms that don't have lots of items that can be used for weapons. So we moved into our new ER. It's great. New Mayo stands that were in all the rooms. It's shiny. The bad part is that the top part came off, so that and then they can separate it. So now my psych patient has a shield and a mace. That was not good. So all those are out in the room, and so use safer things in there, almost like one of these big raising ones that you'd see in an actual inpatient room. So we need a table. We have a couple rooms that have like a garage door that kind of comes down and seals off with all of our blood pressure cuffs and our monitors and that kind of stuff. So if you have somebody who's really agitated, you can lower that down so there's less risk of things being torn off the wall and being in there and stuff. It was great when we had our new ER. We got this, and they were bringing a bunch of dignitary high-end people from the hospital down to view the new shiny ER. And it was like the 3rd day, and we've already got the garage door down, and there's like some dude like banging on the garage door. They're like, oh, we gotta stop them from doing that. I'm like, no, we gotta keep them doing that. They need to see what this place is really like. So, and so you wanna remove all that stuff. You wanna remove stuff from you as well. So a lot of my nursing friends, they like to, wear these cool shears that have like the scissors and the knife and all this kind of stuff on them. I always tell them, don't take that stuff in these rooms. You're just asking for it. Even pins, scarves, that kind of stuff, lanyards for, like your ID badge or something like that. You want to make sure there's a breakaway on the back, so if somebody does try and, grab that, it'll break away. And so you always want to kind of observe it. I always like to just kind of come up to the room, maybe act like I'm looking at something on the ground or something, or on the desk outside, and just kind of watch the patient just a little bit, see what they're doing, how they're interacting with the. We have like mental health techs that can help a little bit, or security guards or whatever, and kind of observe how they're interacting a little bit. And then I might enter the room and kind of see. So you got to control your own emotions. Even though this person maybe, this big, huge person, and you can't go in there and be like, okay, sir, I'm going to listen to your heart now, and you have to kind of act a little bit. So if you don't think you can do that, then it's probably not a good idea to go in there, because they're going to take advantage of that. So you enter the room non-threatening manner. So what does that mean? Does that mean, all right, what are you here for? That's kind of not really the great way you are. What do you want? What are you here for? That's probably not great. So, the other thing so I see this a lot, some people will put their hands behind their back thinking this is non-threatening. But if you're paranoid and delusional, what do you think I have back behind me? Something, right? A shot, something they don't want, right? And so, keeping my hands up, maybe even in front of me, I'm just kind of out. My pockets, so I don't put my hands in my pockets either, so, but you did do that. Don't want to elevate up or anything like that, so it's sometimes hard, because I talk from my hands, so it's hard not to do that. So you want to make some eye contact, but you don't want to get in the staring contest. So that would be, you're not going to win. And so you want to keep 2 arms lengths. So I got pretty long arms, so that's another one. So that's that's good. At least good 4 feet, 5 feet. Gives me at least a couple seconds to, if somebody lunges or something like that, I can dodge, move. I'm pretty shifty, so. And then you want to stay between the patient and the door. So, so our rooms are kind of set up like, so here's your room and here's your door here, okay? And so the bed is right here, okay? There's never a door. Okay. So it's easy to, especially if like the patient's here, we'll make this the patient up a little more. And so, say they have like a laceration in their left arm. Well, do I walk all the way around here to look at that arm? Probably not a great idea. So, the bed's moved. So I can tilt the bed a little bit, move it around the opposite way so I can look at it. I don't have to get trapped back behind there. No. The nurses sometimes they have to start an IV over there, something like that. Still, move that bed around. You just don't need to get trapped back behind there. So you want to establish some rapport with the patient. You may not be talking about anything that the patient is there for. You may say, I like your shoes, I like your shirt. They're wearing some kind of team affiliation. Try and find something that you can talk about otherwise, especially if you've seen the patient before. I haven't seen you in a while. How have you been doing? Trying to talk to them about something. So, if there's an escalation, then you need to get out of the area as soon as possible, call for security staff, and go from there. So de-escalation, so I want to respect the personal space and keep that 2 arms length. That's not always possible. I gotta examine them a little bit. So listen to the heart and lungs, maybe doing a visual exam or doing some neuro exam or something. Okay, looking at that wound from that wrist laceration. Okay. We want to be provocative. We want to have open hands, like I was saying, open body language. We want to establish verbal contact. Usually it's best if kind of one person talks to the patient at a time. It's never good when I'm asking questions, and then the nurse is asking questions, and the security guard is asking questions, and the health techs, they get overwhelmed, okay? And so, I'll often, sometimes I may not even talk to the patient. And so sometimes this is a little bit odd, but sometimes it may be 30, 40 minutes before I actually see this patient. You know, I've got other patients in the ER, I can't just rush over to them right away. And so by the time I get over to them, they maybe already been, you know, made this rapport with our mental health technician. And so sometimes it's nice if I just talk to the mental health technician talks to them. And so there's this kind of they've already established rapport, we're not making a new person in there, asking the same questions over and over and over again. Those kinds of things are kind of hard to do. I may need to ask them a few specific questions. I need to say, you know, it sounds like you can kind of recant the story a little bit so they have you repeat themselves. Okay. You want to keep things simple. When I say repeat often, we don't want to repeat questions, but we want to repeat why they're there and what we're doing for them, those kinds of things. Okay. So we want to identify what kind of needs they may have. You know, they may be acutely psychotic, but they may not know that they are acutely psychotic. Okay. Their need may be that they're thirsty. I want ice water. Why are you guys not giving me water? I just want water. That's all I came here for. No, you didn't come here for that. Your police drug you in because you were wandering naked down the street. But what they want right then is water. Okay? So sometimes you have to kind of figure out what that is. You want to use the free information that you get. So from family, from EMS, you know, sometimes the police will say, yeah, this guy was telling me he was suicidal, but when I got him in the car, we were talking on the way over, it sounds like he just really needs someplace to live. He's homeless right now. That seems to be the great, I can use that information. So that's what I call free information. Or the patient's body language, you can tell their mouth is dry, you know, they're kind of got the little spit bubbles when they're talking, you know. You look really thirsty. You want something to drink? Yeah, I do want something to drink. Great. Now we've made a little bit of rapport. Now maybe I can get some things done. So, de-escalation, okay. Sometimes this works, sometimes it doesn't. Okay. You actively listen. Sometimes you're listening to gibberish. Sometimes you're listening to things that don't make sense. You're letting somebody ramble a little bit. There's a fine balance between this because I've got things to do. I'm busy. But sometimes it takes a couple minutes, letting them ramble, listen, yell at you, whatever. As long as they're not getting too crazy, I will, I don't mean crazy in a negative way, I'm just getting too agitated. Then it's okay. Let them kind of speak, and then you can kind of use things to kind of say, when they say something, you can say yes, but. So you want to start with that yes, but. You don't want to say no all the time. No, you can't have this. Yes, we'll get you some food, but we're going to get your blood first. Those kind of things. Okay? You can agree with the truth of something, the principle. These are all standard things. Okay? Nothing really takes too much. So, but you do want to lay down the law a little bit. So when somebody starts to kind of get a little bit, agitated and those kind of things, and you want to give them some warnings about what, the consequences of the continuing on this road are. We're going to have to sedate you and strap you to this bed if you keep going like this. And let them know that that is a real choice. They have a choice to calm down and take some medicine and maybe feel a little better. And you want to coach them on how to stay in control. This guy, needs to just tell him, we want you to take some deep breaths, lay back, watch some TV, do whatever it is that you want to do to try and calm them down a little bit. Talk to, our mental health technician, but you can't be coming out of the room, you can't be, grabbing things, banging on things. So, set the rules and expectations early. Offer choices, acts of kindness, like giving that water, a blanket, as long as it's safe to do so, okay? And offer medicines too. So, you seem to be very upset. Is there something that helps you calm down? Oh yeah, Ativan helps you calm down. Great. Hey, let's take a ride on the van. Let's do it. So, when it fails, you got to warn that patient that is going to result in, that if keep going is going to result in restraints. Okay, so you want to have all the restraints ready. You want to outnumber the patient, and so sometimes this is easier said than done. Sometimes I'm working with the pregnant nurse and the security guard who is 18 and weighs about 100 pounds and has basically mace. Now they have tasers, which we'll worry about that. So your options may be a little bit less, but trying to round up some other supports, some techs, from the rest of the ER, other doctors, whoever, and kind of getting this patient to kind of sometimes just overwhelming them with the amount of people will allow them to just kind of they'll lay down on their own and realize that they're outnumbered. So sometimes they don't. So when they do start acting and you get all these people ready, you want to kind of swarm the patient, grabbing them by the extremities, the head, and doing a kind of controlled move towards the bed or the ground. Just basically you're just picking them up and putting them on the bed. And then we're going to use some physical restraints, so we're going to tie them down to the bed. So soft restraints, we're going to go through these a little bit more. Leather restraints, which are really hard to use. Most of them aren't leather anymore, they're more like vinyl, plastic. I kind of still refer to as leathers. Called cozies, is what the name brand. And then using the bed itself. So using mechanical advantage, putting some reverse trendeller there, we can talk about it, and kind of putting it so it's hard for them to kind of move and get out of that position. And then I'm never going to use just physical restraints usually. Usually I'm going to do a combination of physical and chemical. So I'm going to give them something, some kind of IM shot usually, to help them calm down. Now we have to get them out of physical restraints. Okay. When they're in restraints, we have to monitor their vital signs. Okay, and round on them. I think it's every 30 minutes if they're required to make sure that they're not cutting into their wrist or that they're doing okay, they're breathing just fine. And then as soon as they're not needed, the patient's asleep, they've passed out from all the activity, the medicines, you're taking them off. Okay. And then once they kind of wake up, it sounds kind of weird, but you want to kind of debrief the patient. All right, what's your name? Megan? Bethany. Bethany, you came in here, you were really agitated. We had to, put you on the bed, restrain you, give you medicines. It seems like you're feeling a little bit better now. The reason that happened is because you got too out of control. We feared for our safety and yours. So we need you to stay like this, and it won't happen again. And so we're trying to talk them into the next one. So, good job, Bethany. All right, so these are the different restraints here. So, actually, brought some props here. I like to do props, so you can kind of pass these around a little bit. Oh, that was almost bad. Okay. So those are soft restraints. I'm not bringing the leathers. What we have, they smell like urine, so it's hard to tell in this little picture here, but so when you have them strapped to the bed, the legs are strapped down to either side, and then the one wrist is up and one is down. Okay, and that helps. So because if they're both down, they can kind of squirrel out and kind of move around a little bit. If you do one, it's much harder. So chemical sedation. This is probably the part of managing psychiatric patients that took the longest for me to kind of understand working in the ER. And so I was very afraid when I first had to order a few things like, ordering antipsychotics or something. That's scary. Now I'm just like, whatever, right? it definitely is sort of a learning curve for sure.
Can you be your friend?
Yeah. So it's going to help us, help the patient as well, all right? So the first thing we'll talk about is benzodiazepines. So I mentioned Ativan earlier, so probably the most common one. Initial dose of 2 milligrams, and repeating every 30 minutes with another milligram until desired effect. So it's called titration, right? So you're titrating to effect. All right? And so, yes, they're getting lots of shots, but sometimes it's needed. So you're gonna use it for sedation, for anti-anxiety, for agitation, and withdrawal. The adverse effects of this medicine are going to be the sedation. So if you give too much, you can sedate them too much. Where now instead of them being in your ER for an hour or so, now they're in your ER for 6 hours. And so they have to be able to walk out of the room, perform their field of go to the bathroom, feed themselves, those kind of things, before they can go to a psychiatric facility. So they get hypotension with this, especially when you combine it with other medicines. So monitoring the vital signs is really important. Respiratory depression. So before you start getting a whole bunch of this, you do kind of want to make sure that they're not having taken some other medicines, a bunch of other things that can slow your respiratory drive, opioids, benzos, those kinds of things. Okay. Antipsychotics, everybody's favorite medicines. So we have typical and atypical, right? Or first generation is a typical. So Haldol is your most common one, okay? Right. It comes in, you can use this IM or IV, but IV is kind of less desired. Got some problems with kind of some pain stuff. So you can give a dose, usually start with 5. If they're really big or something like that, you can do 10. And then repeating every 1 to 2 hours as needed. Okay. So you're using it for more psychosis, mania, agitation for these types of patients. So, you do have quite a few adverse effects, so we have to kind of watch this a little bit. So you're obviously going to get sedation, which is kind of your desired goal, but you don't want to do too much. And then you get a prolonged QTC. Okay, so this is where that EKG comes in. That's why I want to get that. Then sometimes I'm not able to get the EKG because they're too agitated, right? So I have to give the medicine, and then once they're calm, get the EKG. So, but it's okay, usually, if I kind of know ahead of time. Sometimes they have a previous EKG in their chart I can look at. Sometimes, they have some, diagnoses in their chart or something I can look at. That's where computerized medical records is nice, but if I can't get that EKG, I want to do it as soon as I can and see, do they have a prolonged QT, because that might sway what I'm going to give. I need to give more medicines, okay? So they get extrapyramidal symptoms, so the lip smacking, the kind of the tardive dyskinesia, those kind of things. All right. Then you get something called neuroleptic malignant syndrome, okay? That's like a whole lecture on itself, so I'm not going to go into that. But that's like pretty, it's been on a couple of tests I think I've taken this in. One of the answers. So I don't want to look at it. So, second generation, so these are, the most common ones are Zyprexa and Geodon. Okay, I love Geodon. That's it's kind of referred to as the NSP drug. You know what NSP stands for? Next shift problem. So if you give a dose of that, then the patient has next shift problem. I'm sure we get home in bed by the time they wake up. So,
good for a long transfer.
right. So, but sometimes it's needed. So, so it does have a little bit longer effect. So, but sometimes you just need something to get it done. So, had a patient with actually one of your students not too long ago, and the person came in. And I was like in the back of the ER, and I could still hear this person coming in through the front door. The police brought them in through the front door, not to the ambulance bay, so they walked past all the good, fine, upstanding people in the lobby. This person sounded like Chewbacca. Like loud and just screaming at the top of his lungs. He's cut himself everywhere, so he's bleeding. And so.
Not a PA student, I would like mine.
So.
I knew that's what you guys were.
So I heard through the grapevine that this was going to be my patient, so I went over there, and this guy's still screaming at the top of his lungs. They're trying to get him restrained. We get him onto the bed, and he's still flailing. They're trying to get restraints, so I get on top of the bed. I've got my arm like on top of him, and they're getting him tied down. The nurse asks, "What do you want to give?" And I tell him, "20 Geodon." And she's like, "20? Are you sure? This guy is screaming like Chewbacca, and I'm standing on top of him. I'm pretty sure it's all right." So, anyway, we're using more for psychosis and mania and agitation again, okay? The adverse effects kind of breaks down a little bit differently. So, Zyprexa, you get some extrapyramidal symptoms, you get the neuroleptic delirium syndrome, though less than Haldol, and you get some hypotension, okay? Especially get some hypotension if you use Zyprexa with a benzo or Ativan, okay? Use those two together, you definitely never want to get a blood pressure after a little bit, okay? Maybe some fluids afterwards or something like that. Sometimes you have to do it, so. Or sometimes you give, some Zyprexa and it kind of works, but there's still a little bit, so you give a little extra Ativans. You just kind of have to watch that a little bit. The Geodon, you get the extrapyramidal symptoms, not as much though. Then you get a prolonged QTC with this one as well. So it's actually greater than with Haldol. So probably not a great one for your elderly population or people that have had a problem with some things. We got some special population. You mentioned it, elderly. So we'll use lower doses of Ativan, Zyprexa, and Haldol, not that Geodon because of the QTC. People with seizure risk. You can actually lower their seizure threshold. We can't think people have seizures kind of go along this line. It doesn't take a whole lot to throw them off. A cold, missing a dose of medicine, whatever. So if you give them certain medicines, they can lower the seizure threshold. Okay. So using the antipsychotics may not be a great idea. Sometimes you have to do it, but sometimes you want to do that with some benzodiazepines so you kind of counteract that seizure risk. Okay. So pediatric and adolescents, okay, this can be kind of scary. So, and I didn't put one on here. Some of our psych doctors kind of come up with some new protocols a little bit. So we're actually using Thorazine for some of our adolescents, which is a little weird that we're 50 of Thorazine for a 12-year-old, but it works. So I usually like to start with Benadryl, though right now I am Benadryl is like on national back order for some reason, so that makes things a little harder. So you can use Atarax or hydroxyzine as well. Can kind of have that same kind of sedation effect. But some kids have that opposite effect. So younger kids sometimes with ADHD, sometimes you have an opposite effect with Benadryl. So I'm going to ask Mom about that one before. Hey, is there a Benadryl and be going crazy? Yeah. Okay. We're going to give you that. Okay. I can give Ativan a smaller dose. Okay, it's there. Tylenol and Zyprexa as well. Okay. Kind of weird ordering that stuff for a 7-year-old or 8-year-old, but sometimes you just have to do that. And then acute withdrawal. So benzos are going to be your friend drugs. Ativan and Librium. Okay, they're going to be there for a while. Librium's going to be they're going to be a long transport time to someplace or something like that. Librium's a little bit longer acting. So the most common psychiatric patient is the suicidal patient. Okay. It's just rampant. Part of it's the homeless population because it's something that's kind of easy for them to say something going on, trying to get some help or whatever, stay out of the cold or hot. Okay. But we're going to take it seriously initially, at least, okay? So we're going to keep them safe while they're in the emergency room. So we have all our psychiatric patients do a screened by the security guards, so they go through all the property, make sure they don't have anything, they lock up all their bags and whatever they come with, coats and jackets and everything. We change them into some paper scrubs, and so they don't have any real way to harm themselves with their clothing or have a knife in their boot or anything crazy, which used to happen a lot when we did do this. We want to have a guard or a sitter with them, so like I said, we have mental health technicians that do this, so there's a text. Usually they're people that are good at talking to people, and not security guards. They're not, you know, they're not going to be tackling people and those kind of things, but they're going to kind of watch and let you know when somebody's getting agitated, and you know, they give us, like I said, they can establish rapport with the patient a lot more than what we can sometimes. So you want to evaluate the threat. You know, what is their plan? We mentioned this kind of before. So, you know, is their plan realistic? You know, is a homeless person going to have access to a gun? Maybe. It's a little more unlikely than it is, but you know, do they have, you know, if they're a normal person that's not homeless, you know, do they have weapons at home? Even though they tried to pass a bill not too long ago, saying that we couldn't ask about, make some rules about how we weren't supposed to ask if people had weapons in or guns in their home, which is just ridiculous. But we definitely want to ask about that, find out, you know, especially for a child or something like that, you know, can you lock up any guns? Can you lock up the knives that this person's making threats about? You know, those kind of things. Can somebody safely watch them? Do they have a significant other that, you know, can keep an eye on them? A parent, a friend, you know, somebody like that that can do that. And make sure that they follow up too. So the attempt, this is one thing that's a little bit more serious. So, you know, somebody's actually done something, attempted hanging, occasionally, sometimes it's not initially known, and then you start asking some questions, and like, well, this person like actually hung for a little bit. Well, that things get kind of serious. You know, make sure that they're, you know, if they're sitting there talking to you okay, they're maintaining their own secretions, that's usually a good sign, but things can have a delayed effect. You know, you get some hematoma in the neck, that's some things that can cause some problems. So anytime, like general kind of rules, that they have a ligature mark, there was a hanging, more than just kind of wrapping a rope on around their neck. You know, if there's any type of actual pressure on the rope, I'm going to get a CT of their neck, a CTA of their neck. Make sure they don't have any vessel occlusion, there's not a hematoma in there. You know, snap a trachea ring or anything like that. So those are all important things to look at. You know, cut themselves, so lots of cutting. Some of it's just scrapes or you know, burns or marks, you know, fingernails or whatever. Sometimes people do some really serious lacerations. So you know, sometimes they're we'll get down and they'll have blood vessel involvement, or they actually need, you know, to go see a hand surgeon before we can even worry about their you know, psychiatric treatment. We need to get that hand fixed. So we might need to transfer them to a trauma center or somebody that has a hand surgeon that way. So those are things we might need to look at first. So gunshot wounds, we don't see a whole lot of this in Saints because we're only do intermittent level 2 trauma, but you know, sometimes people sometimes don't tell you everything. So sometimes you're getting somebody undressed, like, why do you have a hole right here? Oh yeah, I shot myself. Great. Well, that changes lots of things. Overdose and cutting are probably the two most common things that people do. Throwing somebody in the traffic, that's more of a threat. People say they can jump off something or throw something into the. So statistically, teens to 30-year-old males are the most successful at suicide. So if somebody's threatening in that age group, that tends to, when I'm having those discussions about taking people's rights away versus, you know, keeping them safe, is one thing that does injure their mind quite a bit. So some people will tell you very specific what they took. Other people will just say a whole handful of this, a handful of that. You know, so using if you have a good EMS person or police officer, they'll bring the bottle with you, so you can kind of tell, this person had this medicine filled on this date, there should have been this many pills left today, and now they're all gone, or there's only one missing, so maybe we just take a couple extra. So you kind of have to play Sherlock a little bit with this searching. Sometimes family members can help, sometimes. Let's see. Oh, pumping your stomach. I've only seen this done one time, and so we actually had this not too long ago. So we had a colchicine overdose. What's colchicine used for? What? No. You could try that.
Somebody over here
Oh,
said
yeah.
Gout.
Gout. You're supposed to-
Yep. Good. So, yeah, and so this can really have some very serious effects. And so if they overdose on this, and it's with any kind of reasonable time, they probably might consider actually doing a gastric lavage and trying to get any extra pills out because this was so bad. So our general rule is that we call poison control. And you think, well, what's poison control going to tell me about these medicines that we should all know about, or a doctor should know about? Because we actually have some good, these are toxicologists. I mean, these people know what's going to happen with these things. So, especially household chemicals or products that you're unaware of, this is really great. So favorite one is had a 5 or 6 year old, and every time you buy a product, they have these little packets in there, they're desiccants to keep things dry, right? And big letters on there, do not consume, all this kind of stuff. So we had a kid ate 5 or 6 of these packets. So I don't know why they had 5 or 6 of them, but they did. So I was like, oh man, that sounds serious. It's really bad. I mean, all these things say don't eat, don't consume, call poison control. Guy's like, oh yes, okay. Well, yes, the most common side effects patient's going to be experiencing. What do you think? Dry mouth. Yeah. So that was basically it. So give us more. So not as bad as they basically, but I wouldn't recommend it. So the bad ones that you've got to look out for are insulin overdoses, blood pressure medicine overdoses, colchicine. There's a few weird ones in there. Those kind of things are ones that you definitely got to look out for, and probably want to do an ICU admission, even if they're doing okay, just because they can get really unstable later on. You want their vital signs monitored constantly. You want them to have good nursing support. Manic behavior, these people are fine. Often kind of found wandering around, disheveled, hyper-religious. They have all kinds of gaudy jewelry on, or they're very exotic clothing. Nobody here looks okay. Good. Most people who have bipolar disorder lead very normal lives. Sometimes though they have some stressors in their life that cause things to kind of go haywire. Their substance abuse gets out of control. They have personal things going in their life, family problems, all this stuff. They stop taking medicines. They run out of their medicines. Somebody has to change their medicines. Some of the times we see people telling us, I was on Seroquel for this many years and it worked fine. Yeah, it worked great. And they had one side effect of it made them a little drowsy or something like that. It really wasn't affecting their daily life at all. They're still working, and they go and change this medicine totally up, and then now they're completely manic and having to do a psychiatric admission. It's like, is this really worth it? So sometimes you got to weigh that if you're changing medicines for 1 or 2 little side effects. So. Anxiety is probably the one that, when you see this as your chief complaint that pops up on the board, you kind of roll your eyes a little bit more. But so people are very anxious, and so sometimes if you just give some people some time, they can actually kind of calm down by themselves. Panic attack is real. We can get people who have panic attacks, and they actually will get real symptoms from it. So we'll talk about that in a second. So, but they also usually come with maybe a complaint that is more medical than psychiatric, so chest pain or dizziness or your vision's off or something like that, tingling. So you have to kind of take that seriously. You want to make sure that there's not some kind of issues. We do a lot of probably unneeded chest pain workups on anxiety things, but it's not worth the risk not to do that. And miss somebody that's having a heart attack. So. Some people need medicine. Some people just need resources for counseling or get referred someplace. We typically try not to use benzodiazepines, especially for outpatient scripts. We might do a little Atarax or Visceral for kind of a stopgap to kind of get them through until they can see somebody. The hallmark of an anti-anxiety medicine is actually antidepressants or SSRIs. So if they can get on one of those, it can help out a little bit. So Atarax, hydroxyzine can make you very drowsy, so I will warn them about that. So the panic attack is actually get somatic symptoms, autonomic nervous system stuff, so shortness of breath, tachycardia, tachyphoresis, headache, nausea, vomiting, shaking. So actually, the pulse actually elevated. So actually, we take that into consideration. So you might need a little bit of treatment in there to calm down. Don't use the paper sack to breathe in there. So they're just going to end up with some CO2 retention, and you're worrying about a whole other different ball of wax there. So rule out medically and make sure they're medically stable. Drugs and alcohol, all right. Many people come in seeking some kind of treatment for this. Most places don't have a whole lot of resources to offer in their hospital themselves. At Saints, we actually have a medical detox. It's not for everything. And some people don't need a detox from different things, or they haven't used it enough that they need. Sometimes you get a concerned parent, they bring their family member in. Rightfully so, they're concerned about, they found out that their son was doing some methamphetamines. They've only done it a few times. This doesn't really need a detox from it. It's not like they're doing it every day, but they definitely might need some help with some counseling or outpatient resources. So we have a counselor in our ER that actually kind of helps us write our EOD paperwork and see all our patients, do assessments on them. So they actually can help us find somebody to get them to see. So we want to make sure that if somebody is, sometimes they come in and like, I'm done with this alcohol, I've stopped it, don't worry, doc. I just need some help to kind of get through. How long has it been since your last drink? About 24 hours, and they're sitting there shaking, and like, okay, well, that can be bad. We don't want to, sometimes stopping cold turkey isn't the best thing for everybody, so believe it or not, we'll actually recommend people to keep drinking. It sounds counterintuitive, but if you can't, you can't get somebody in until after the weekend. Sometimes it's better for the patient to actually keep drinking throughout the weekend. I'm not saying they should drink, until oblivion, but have a drink or two is probably better than trying to quit cold turkey and go to withdrawals. And so that's kind of seems kind of bad, but that's people are like, are you telling me to keep drinking? Kind of, yeah. And so we can give them medicines, but if they drink and take the medicine, that can be really bad as well. And so you need to make sure that they have a reliable person before you're doing that. You're basically trying to do an outpatient detox with this person who you're never going to see again. So you got to kind of take that into consideration. So the common symptoms of some withdrawal, like nausea, vomiting, headache, myalgias, tremors. Opioids kind of just suck. Meth just kind of sucks. Marijuana, when they come off of that, definitely nausea and vomiting. There's something called cannabinoid hyperemesis, which is awful right now. The THC content in marijuana these days is sky high, and so causes hyperemesis syndrome, where you can't stop vomiting and get dehydrated and end up in the hospital. So it's, people actually, when they smoke, they'll actually get a little bit of a relief. But it's a cyclic thing, so you smoke marijuana, you get a little bit of relief, but then your THC levels go up, causes the vomiting. So you have to break that cycle, but people don't believe that it's the marijuana because it's the only thing that helps. And so they try every kind of nausea medicine, and nothing helps, and eating doesn't help, not eating doesn't help, but that marijuana helps. It's the only thing that helps. That and hot showers. So that's the common thing. Is, for vomiting, for this kind of stuff, the only thing that helps is when I smoke the J, and then after that I'm okay for a little bit, then I start vomiting again. I've been in the shower like all morning, and as soon as I was okay while I was in there, as soon as I get out, I start vomiting again. It's like classic. And so we gotta watch out for that. So I get tired of seeing that. It's really hard to convince people that it's not. What were we talking about?
CBD oil, do anything with that, or it's just the
No.
actual smoking? I just want you guys to know the
Yeah.
difference and which ones.
Yeah,
And what about
oils and-
K2 or any of those products?
Yeah, K2 is bad in its own right. That causes more psychotic delusions.
But it doesn't call it.
It does not call all
It's
that stuff.
not a cancer.
So let's see. So opioids, meth, THC, cocaine. There's not really a detox that are needed for these ones. They feel horrible. You feel like you're going to die. You feel like you have the flu or something bad. And, the biggest thing we see with this is they get dehydrated because they're nausea and vomiting. They're not eating and drinking. So they can get some rapid analysis with this. So you have to be careful with that. Benzone ETH, you get a huge seizure risk for these. Plus the DTs for alcohol. Okay. So treatments are using fluids, using benzos, using antiemetics. So there's DTs. I was ahead of myself. Usually about 24 to 72 hours after the last drink. So it starts more as just some tremor. They get more confused, hallucinations. Okay. They get dehydrated, seizures. So you got to get on top of the fluids and Ativan quickly. Give them some thiamine, so it's B vitamin that gets depleted. So multivitamin, folic acid as well. I just kind of feel weird ordering a multivitamin in the ER, but sometimes it does actually help. This scoring system, it's kind of more of an inpatient thing, because the person with DTs, they're being admitted to the hospital. And so, but you can start this in the ER, it helps you kind of figure out what level you need to start this person at as far as medicines and how often you need to any of these things are on MD Calc or any of these things you can look up. So the emergency psych, so the goal is to make sure the patient's medically stable. That's always your goal with any patient, whether they come in for a toe pain, or abdominal pain, or some kind of psychiatric issue. So they may not tell you everything that's kind of going on, but you need to kind of go through your process, make sure they have normal vital signs, there's no cuts or scrapes on them, or gunshot wounds they didn't tell you about. You need to kind of go through that, make sure they're medically safe first, then you can worry about finding them replacement. So most people that come in get outpatient resources, okay? And sometimes it's frustrating for people because they, especially for child psych, there's a big difference between behavioral and psychiatric. So somebody's just aggressive and agitated, and they're throwing things, biting, kicking, smearing feces. Those patients more are behavioral, and so they qualify more for something called residential treatment care, which is some more long-term care. It's usually not admitted through the emergency department, so they have to have like a separate evaluation for that. You have like intensive outpatient treatment for psychiatric services that they might qualify for. So basically, they come to our facility to go to school, and then they get counseling a couple times a day, or see a psychiatrist once a day, and they get this intensive outpatient, but they also get their schooling. So it's kind of helpful for a lot of patients. Inpatient, most of our patients that come to us, even though we have a large psychiatric facility, don't actually stay with us. We are going to move them to a crisis center. So these are state-funded or county-funded facilities, and they basically do another evaluation, see if they can get them outpatient services again. If not, they transfer them to a state facility or keep them there. And so state facilities are ones like Griffin, there's places in Weatherford, and Tulsa, and crisis center in Oklahoma City, Red Rock, these kind of places. And they're usually there for a couple days. They maybe get stabilized a little bit, started on some medicines, given resources, and guess what? They don't follow through and come back, and it's vicious cycle. So we don't. There's a lot of abuse to the system. We don't institutionalize people. There are some growing kind of things where people are getting help with some housing, and the housing is kind of together, and there's support of their caseworkers and stuff like that, the housing that they can kind of help kind of get them more stabilized, get them so they get a job, and once they get a job, then they can move out into their own place and manage themselves better. So that's kind of the more ideal situation, though it doesn't happen for everybody. But so if you don't have insurance, you don't have certain things, you're going to a crisis center, you're getting out, you're going to basically a free clinic, and hoping they can provide medicines to you, and hoping that you take those medicines, and you don't follow up, and if you're on the streets, maybe somebody steals your backpack, and it's got all your medicines in it. What do you do? You're back in the yard. So sometimes these things are actual, they have real stressors. If you're homeless, it's really a stressor, I'm sure. So I think I would probably do the same thing if I was homeless and it was cold outside. I'd probably look for a nice warm meal, get a box of lunch and a blanket. Sounds reasonable to me. Most people say they're going to be suicidal. They just want free huts and a cot. They want a place to stay for a little bit. But you just have to figure out, are you willing to bet your license that they're not going to go do something? Because even though this person may be homeless and they have burnt every bridge with every family member, I guarantee you they end up dead. The family members will be crawling through the woodworks to try and sue them. So that's not something you want to mess around. So pediatric psych, so about 3% of all ER visits for children is for, in adolescents, is for psychiatric stuff. So that's quite a bit. So we're seeing, everything from colds to, broken bones to whatever, and we see a ton of jobs. I bet ours is probably higher at Saints than anything else. Just mainly because we don't see as many kids for other stuff, because children's is right down the street. So most, there's some unstable family there. There's abuse. They're in their 4th or 5th home, DHS, places. There's some aggression, there's SI, there's not as much psychosis, but there is, sometimes you'll hear some kids talk, and they're actually hearing voices and saying things, and they're 6 years old. And that can't be good. You always kind of wonder a little bit, is it more of, parents say, well, they hear something, they talk to somebody, my kids talk to like an imaginary friend. But is their imaginary friend telling them, kill themselves? That's when it becomes a problem, right? Most of the drugs that we use in kids are understudied, so and some of these kids are on massive amounts of drugs. They're on SSRIs and antipsychotics and Abilify and all these type of things, and clonidine and amphetamine. These kids are so doped up. You kind of wonder what the actual kid actually is like. So, if you're concerned about the kid being, abused or anything like that, sometimes the kids will come in and say that they are abused, and you have to take that seriously. I just tell the parents, that look, they're saying that they're being abused, we have to take this seriously. If we don't, we're going to see a problem. It's pretty obvious that the kids aren't being abused, but we have to take it seriously, make a report. So you can call Barry E. Nichols, your friendly child welfare specialist. Okay. Somebody, one time when I use lectures, is going to know this person. All right. Questions on site?